Good morning, everybody. This is Morgan Denny coming to you live from Portland, Oregon, where for the first time at a beautiful, brilliant 5:30, it is actually somewhat light outside, which is a very, very lovely change. So before we get started this morning, I want to give you guys kind of a heads up on what's going on with ICE in the next couple of months. We've got an extremity course coming up with Eric Chaconis over in Vegas. We've got 2 total spine manipulation courses going on in Pennsylvania and Georgia over the next couple months. We've got some live fitness athlete courses with Mitch and Zach happening coast to coast in Connecticut and California. And we have got a cervical spine management course going on taught by your very own Jeff Moore the first weekend of June. So if any of those is somewhat in your neighborhood and you're interested, just get out there and get some stuff learned. So this morning, the topic that I wanted to talk about was blood pressure. If you guys have ever heard me talk about blood pressure, if you're on virtual ICE, you know that this is a really important topic to me. And I really, truly believe that as PTs, we need to be playing a larger role in the general medical community in terms of being able to help manage the cardiovascular problems going on in our country right now. So today I wanted to talk about 3 different tests you can do that utilize blood pressure measures to kind of get the right things going on for your patients at the right time and the potential referral to someone if we're not the appropriate person to be seeing them, or if they need some additional care for that matter. So the first thing that you can do is you can take their blood pressure. So I know 3 easy tests that involve blood pressure. Numero uno is definitely just take their flippin' blood pressure. You know, this is something that's going to help us screen out people who are prehypertensive or who are in stage 1. So remember, guys, anything above 120 over 80 is considered out of the normative range. So keep in mind that anything from 120 to 140 over 80 to 90 is considered prehypertensive and stage 1, right? So in those stages, that's an appropriate place where we can start educating people about some lifestyle changes, not necessarily referring them right away, but giving them 2 to 3 to 4 weeks to make some of those changes and remeasuring and making sure that blood pressure is coming down is also important, because people on average can get like 10 to 12 point different changes in their systolic blood pressure using simple modifications in nutrition and stress and sleep and all those kind of traditional things, plus exercise, of course. But we need to make sure to monitor those things. Now, also be aware that anything above 140 over 90, in the medical community, doctors are advised to start medication at that point if that number stays in the range of 140 over 90 or above, independent of the idea if they have other disease process going on. So just keep that in mind so we know and we can be aware as pieces of the medical community that if patients are staying in that 150 range or in that 95 as a diastolic range, keep in mind that it's an important thing to be able to refer patients back to their doctor so they can kind of at least get the discussion going of whether or not they want to get some pharmaceuticals on board to start kind of maintaining blood pressure at an acceptable rate. So keep in mind that that's an important piece, right? The next test I want to talk about is the ankle brachial index, the ABI test. So this is a test we're going to use if we suspect kind of a vasculogenic cause of some lower extremity pain, right? So this is screening out peripheral arterial disease, which is coming to be a little bit more common in our society with a lot more cardiovascular problems going on. So important that we know as medical providers, not only kind of the signs and symptoms that indicate this, but again, another measurable test that we can use. So this test is using the blood pressure that we're getting in the ankle, in the lower extremity, as a ratio over the blood pressure we're getting in the arm, right? So the way this test is taken in a truly medical and very research-oriented way is you have the patient lie supine for 10 minutes, and then you take the blood pressure in both of their arms, both of their brachium, and then you take their pedal or their pressure in both of their ankles, right? So this can actually be done at the arterial part in the medial aspect of your ankle or at the anterior. So whichever is a little bit more superficial, more palpable for you as the clinician. And you can actually use an automated blood pressure cuff to do this, as well as using your traditional stethoscope measure. However, it probably depends on the size of blood pressure cuff that you have in your clinic and the size of your patient. So just keep that in mind. But using this test is really, really important because if your patient comes in and they're presenting with any kind of paresthesias or numbness in the feet or the ankles, or if their symptoms just don't seem to match any kind of neurologic pattern, like a peripheral arterial, like a peripheral nerve pattern, or potentially kind of like a spinal nerve root pattern. If they're not matching some of those aspects that we have been taught to measure, then this is a really good test to go back to kind of screen out that arterial involvement. So remember, you're going to have your patient lie supine 10 minutes, take both the arm and the leg blood pressures. Now, when you do this test, you're going to take the blood pressure, the systolic blood pressure of the leg that's involved or the leg that you're testing for. So you might have to do 2 ratios. Oh no, right? So you're going to take that blood pressure and you're going to put it over the highest blood pressure you got between both arms. Now, within that measure, and don't worry, you guys, you're allowed to use your calculators on your phone to get this one right. You need to get 1.0 to 0.4 for your patient to be, or 1.0 to 1.4. Let me enunciate that. For your patient to be considered in the normative range. Now, it's also said that 0.9 to 1.0 can be an acceptable measure, but they need to be somewhere in that 0.9 to 1.4 range for you to think, or at least be confident, that they don't have peripheral arterial disease. Now, anyone that's above 1.4 in that ratio probably has a hardening or calcification of those blood vessels and should be referred to the appropriate clinician. So either their general practitioner or to their cardiologist, someone like that. Now, anyone that is below that 0.9 in terms of their ratio, that's an indication that peripheral arterial disease is probably on board or some kind of cardiovascular involvement. So if you're getting those kind of numbers, be sure you're sending people back to their cardiologist, back to their general practitioner, because the symptoms that they were sent to you for or that they're telling you about are likely not just simply orthopedic or neuro, right? They have some cardiovascular involvement. So it's really important for us to start getting the appropriate treatment on board because it's probably not just going to be joint manipulation and exercise, right? So key component, the ABI test, the ankle brachial index, we should be using this. Now, I know what you guys are thinking, have a patient lie still for 10 minutes and then take 4 blood pressures and then, oh my gosh, do math. That sounds crazy. Who would ever have the time for that? I mean, if you're me, you have 30 minutes with each patient. How are you ever going to be able to take 15 minutes out of one appointment to get this measure taken? What I would argue is at the end of your appointment, have your patient lie still for 10 minutes and then instruct one of your aides or your assistants to go in and take the blood pressure on each of the 4 limbs, document what they are, and then you, lucky clinician, get to do the math later. Right? And that way, if you're finding that some of these things are on board, you can go back and talk with your patient about them at their next visit or call them and their doctor so they can get that appointment going as soon as possible, right? So that's your ankle brachial index. It's kind of hard to say that in the morning. Ankle brachial index, your ABI test. And you're actually going to use that with any patient that has lower extremity issues that are not fitting a pattern that seem to be an obvious peripheral nerve pattern, spinal nerve root kind of pattern, stuff like that. A lot of these will present as kind of distal, non-specific, not kind of in that pattern where you're seeing specific toes or specific dermatomal distribution, that sort of stuff. Also important to keep in mind, you guys, that in the medical community, they advise doctors, all of the cardiovascular societies advise doctors to do this test as a normative standardized test for any patient who is a known smoker or a known diabetic that is over 50 or any patient over 70. So as becoming a part of kind of the medical society and medical community, I really believe that as PTs, we need to know that these are important tests to do. So if you have a patient walk in that you know is a smoker and is 64, no matter what their symptoms are, even if they're coming to you after a total knee, it's probably important that you get some of these measures on board just to make sure that this isn't a factor that you can screen out for this person, help them avoid a more intense complication, and just kind of get that part of your treatment rolling, right? And that might mean that the doctor decides that it's not a bad enough cardiovascular involvement to put them on meds yet. But that might mean that as part of your treatment, you incorporate a lot more aspects of nutrition and stress and health and doing general stuff to really get this patient going in terms of exercise and diet and stuff like that. That way, you're starting to help work on that cardiovascular issue with that patient. And also, you've caught it at a point that is before some of those downstream effects have occurred that may or may not be reversible. I've definitely had patients that I found this in who have been seeing me for things not related or related, where they've had strange shooting pains, spasms that come on, while driving or doing something that seemed very unrelated to like a neurologic pattern. And so when you stop and go back and use this test, which is super easy, guys, it's just the measure of the systolic of the ankle involved over the highest brachial blood pressure you have in that patient, and looking at that number, making sure it's between 0.9 and 1.4, so that can really help you screen these things out and get the appropriate treatment on board. So last test I'm going to talk about today is using the blood pressure between two arms. So the ABI helps you know if you have a lower extremity that's involved, that has arterial involvement. But being able to use the blood pressure between both arms is actually something that's been validated in our medical society as being indicative of there we go. Indicative of stenosis of the subclavian artery. So that's one we can use really easily as well, and it doesn't require the patient being still for 10 minutes, technically speaking. But if you think that the person has some arterial involvement for their upper extremity, just take the blood pressure in both arms. If you see a difference in systolic blood pressure that is greater than 10, that's something where you want to start getting other people involved or send them out back to their general practitioner or their cardiologist, because anything higher than that, and we start thinking that there might be arterial involvement. What they found is that a systolic blood pressure that had a 15 or greater difference had a really high likelihood of having that stenosis in their subclavian artery, and anything between 10 and 15 needed a lot more investigation to find out exactly what was going on. Now, remember, guys, this test, just like our normative blood pressure tests, can come out as looking a little bit different day one if the patient is stressed, if they have white coat syndrome because you're making them nervous, because, oh my gosh, they're at the doctor's. So if this is, on the positive end or close the first time you take it, this is something that you put in your back pocket. You keep in the back of your mind and you take it again the next time and the next time. But if you have consistently a measure that it has a difference of 10 to 15, this is something that you really want to refer back to their doctor for and get on board. Now, I'll also tell you that as someone who's referred back to doctors for this before, I've had patients go to their doctor, they take their blood pressure both arms, and the doctor sends them home and says, "You're doing great." And then they've come back and I've said, "Hey, let's talk about that a little bit more." We've pulled up the blood pressure tests that they had because luckily we've got, electronic charting now, so patients can look at their own charts. And you go back and look, and that patient has that great difference. So this is something that even some physicians aren't necessarily aware of, looking for that difference. So remember, guys, it's important that we kind of keep educating even the physicians that we're working with on some of these type of things. So, with that patient, I called her doctor and I discussed kind of the possibilities, and I told the doctor how the symptoms weren't necessarily presenting in a way that made sense to me, and how I used this test, and I kind of told her about it, and she was like, "Oh, that's a really good test to know about." So it's important that sometimes we assume that the people that we're working with are around us might have a grasp on all these things, but they're looking and checking so many different things that potentially they're not specifically checking for the things that we are or concerned about those aspects. So it's important for us to be able to also call that doctor and say, "Hey, I've got symptoms A, B, and C on board. This is what I'm thinking with this patient. I think a little bit further screening is important." And as long as we're presenting it in a good way, doctors are going to be really happy that we're finding these things. Again, guys, getting patients the treatment they need in an appropriate time frame is key for preventing the onset of further cardiovascular complications, or for them getting to a place down the road where that patient has to deal with a lot more, or potentially can't find a reversible lifestyle modification that they can make to deal with it, right? So a lot of these patients, we're going to be using this side-to-side difference to screen out symptoms, but also to realize that we're looking at preventing further compromise of their upper extremity or a potentially worse cardiovascular event, right? So remember, guys, these tests, the ABI, the side-to-side arm test, and yes, your general blood pressure testing are really important because we're starting to help the medical community get ahead of this blood pressure problem and screen these things out for patients so they don't have these complications down the line, and that potentially we can use some lifestyle modification factors to kind of break that cycle so people don't end up in the medical community. That's us, actually. If they don't end up kind of working through the medical circuit, right? So remember, guys, if you have a patient come in who has arm or leg symptoms that have paresthesias involved or numbness or some tingling, stuff that's not following a peripheral pattern or a nerve root pattern where their dermatomes and their myotomes and their DTRs aren't all meshing together, these could be patients where we've got arterial involvement going on. And we might want to work on using some of these tests, the ABI test or the side-to-side arm blood pressure test or just standard blood pressure to screen out and make sure these people don't have arterial involvement. So you guys, blood pressure is a super useful tool, and it's one that we already know how to use somewhat. We just need to use it more consistently and potentially in a more specific way. So have a great Tuesday and go measure some flippin' blood pressures, people.